Awesome. Okay. Good afternoon, everybody. We're going to get started again. Welcome back. So I'm Sarah Heil. I'm going to be the chair of the afternoon session. Like the morning session, each speaker is going to be presenting, and then once again, we'll have a general Q&A at the end after all the speakers have given their presentations. If you're here in person, please come up to one of our two microphones to ask questions. And if you're attending virtually, you can put your question in the Q&A window and anytime during the presentations, and then we'll incorporate as many of those questions into the Q&A along with questions from folks here in the room. And also all these sessions are being recorded and will be posted to our website and our YouTube channel after the conference. So we have three speakers this afternoon, and we're going to be starting with Jesse Dallery. Jesse is a professor in the Department of Psychology at the University of Florida and a licensed psychologist in the state. He received his PhD in clinical psychology from Emory University and completed his postdoctoral fellowship at Johns Hopkins University in behavioral pharmacology, which is where I first met Jesse. His research is translational in nature and has addressed a really wide range of topics, including human laboratory studies of choice and decision-making, addiction, nicotine and smoking, contingency management for smoking cessation, for physical inactivity, and for medication adherence, mathematical models of operant behavior and intertemporal choice, and also matching theory. But a unifying theme that holds all of these different areas together is the development of technology-based interventions to promote health-related behaviors. He regularly publishes in both basic and applied journals, and his work has been funded by major grants from NIDA. Jesse.
Hello, everyone. I'd like to first note that I have no actual potential conflicts of interest, and I'd like to acknowledge NIH and PCORI for funding. Here's the question that's at the core of my talk today, which is, are we entering an era of impact of digital contingency management? And my answer is yes. The stage is almost completely set. So I think it'll be instructive to take a look at how we got here and to be more specific about where we might be going. So first, I'd like to address the question of what is impact. Here's a definition of impact from the RE-AIM framework. We already know that digital CM can expand reach, it's scalable, it's efficacious. In terms of implementation, it's engaging, acceptable, it has no side effects. It's automated. And because it's automated, it entails low staff burden in terms of training and ongoing treatment delivery, and also it affords high fidelity. In considering the question of impact, we can also ask, what are the contextual variables that are driving impact? And here are a few of the key variables. Number one is obviously the technologies. We saw a shift from using computers to smartphones to access digital CM. We've also seen the rise of digital CM companies as well, and the incentives for those companies, the financial incentives for those companies. Also, the customers of those companies being reasonably convinced that they'll receive a return on investment for using digital CM. We've also seen changes in policies over the last 17 years, including a rapid change in policies during COVID in terms of remote delivery of all sorts of therapies. And all of this enables greater resources in terms of accessing the technologies to deliver digital CM. So they have been, digital CM has been implemented in several community settings, which I'll talk about. It's easily adoptable. Maintenance may be a little bit trickier. It's relatively new, but the fact that we can even start addressing the question of maintenance is an exciting advance, I think, in this area. And last consideration here, in sort of a motivational factor for many of us in developing digital CM, is that equity gaps exist between those that need treatment and don't receive it, and those that need the treatment the most, those that are most vulnerable and are also less likely to receive treatment. So these contextual factors can mitigate and have mitigated against these equity gaps, including what might be called the original equity gap, which was that traditional in-person CM was only available to those that were near a treatment clinic. And that's why we started to, why I started to investigate technology-based methods to deliver contingency management in the early 2000s. And since then, there's been a steady evolution, I would argue, of these methods and their impact, largely driven by the contextual factors that I just noted. And here's what that impact might look like over time. So starting in 2005, and then slowly increasing in impact as we see new technologies become available to detect drug use. The advent of smartphones, we started this research before smartphones were even invented. And then around 2016, the development of several digital CM companies and science industry partnerships. And then again, there's sort of a recent uptick in remote methods of all kinds due to COVID. And we can anchor this hypothetical graph with scholarly activity in the area. And this is the cumulative number of articles published since 2005. So again, the number starts off slowly, but then gradually increases around, starts to more rapidly increase around 2013. And then as science industry partnerships begin and new drug sensing technologies become more available, we see an expansion from smoking to drinking and then other illicit drugs. So we conducted 10 of these studies between 2005 and 2015, including this one in 2005. Although the technologies have changed over time, many of the elements here are still in play even today. So namely that we are still obtaining video or selfie verification of drug status and user identity. In this case, this is a breath carbon monoxide to detect smoking, where we can obtain samples twice a day, 7 days per week, on average around for a treatment period of around 2 months. And everything is automated in terms of feedback, incentive calculations and delivery. And with some caveats about internet connectivity, this system could be available anywhere. Before I move on, I want to be clear about what I mean by technology-based CM. And essentially, there are two components that are mediated completely and automated by technology. That is assessment of behavior using breath, sweat, or saliva, and the consequences. In all of our studies, we use monetary consequences, social consequences in terms of feedback from study staff, or if they're automated feedback, it might be called quasi-social feedback. And also graph progress. So graphs were also a very highly liked feature of all of our studies in terms of participants. The monetary rewards were delivered via debit cards or PayPal. There's a third component too, which is user authentication. We need to verify the identity of the end user. This is technology aided in the form of web cameras or cameras now on smartphones. But for the most part, we still need to manually verify, look at the video or picture to authenticate the end user. Some groups are starting to use facial recognition, and I'll come back to that later. So we applied this method to heavy rural and adolescent smokers and adolescent rural smokers across several studies, single case experiments and randomized controlled trials. And regardless of the control conditions, we see about a 3 times higher rate of abstinence compared to the control conditions. You'll notice here in this figure, this is North Central Florida. These are from our earlier studies. This is still an advance in terms of our ability to deliver contingency management for smoking cessation. It would have been hard to reach these folks. It gets rural very quickly outside of Gainesville. And they can't come to the university twice a day, 7 days a week. Most days there's no parking on campus, so that's out of the question. But this is a relatively restricted geographical area, and of course, technology affords even greater reach. And so we conducted a small randomized controlled trial where we made the treatment available to any qualified smoker in the United States. This is a platform called Motivate that was developed by Mike Grabinski. And here, everything is automated by Motivate. The voucher calculations, voucher delivery, and that voucher delivery is available immediately upon sample submission, breath sample submission. This is the point prevalence of smoking abstinence. So we're looking at the percentage of negative samples across baseline, 4 weeks right after or during treatment, and then 3 and 6 months post-treatment. So the group differences persist at the 3 and 6 month time points. However, these are not statistically significant, which could be due to a power issue. So the AC group is the contingent group, and SC group is a submission condition control group. This figure shows the location of each individual in our trial. So relative to my previous figure, you can see quite an expanded reach here. Of course, ideally, what we would want to see is a map that is completely blue. And that's a political statement, if you'd like. So as we were conducting this study, mobile smartphones developed rapidly. And in 2013, the first smartphone-based contingency management study was published by Hertzberg et al. And one characteristic of all these studies that have used smartphones since is that they are generally targeting vulnerable populations, homeless veterans, low SES. Ours is one of the only, is an exception where we enrolled regular smokers, smokers with ADHD and PTSD was the population for Hertzberg. Hertzberg study was actually a small randomized controlled trial as well. And at the 3-month time point, follow-up time point, 50% were abstinent in the contingency management group relative to 13% in the control group. And this is the most recent that I'm aware of, the most recent iteration of mobile contingency management conducted by Allison Curti and colleagues. And the target here is peripartum smokers, and I know many of you are familiar with this study because it was conducted here. And they also did nationwide recruitment and enrolled smokers from 33 states. The two groups were best practices and best practices plus CM, and Dynamic Care Health developed an app, their own app, to obtain video of breath carbon monoxide and then later salivary cotinine with the Alere test kit. And here are the results. This is a point prevalence abstinence at various time points during the study, before and after pregnancy. So you can see a 2- to 4-fold difference in abstinence across these time points, including a 4-fold difference in abstinence at the 24-week time point, 24-week postpartum time point. And in February of 2022, the FDA, based on these data, granted breakthrough device designation for this as a prescription-only digital therapeutic for peripartum smoking. Monitoring systems for alcohol have also been advancing. This is just one example. This is the SoberLink breathalyzer. So as you blow through the mouthpiece here, it automatically takes a picture, and there's facial recognition software already embedded in the system. So in this study, it was 40 individuals diagnosed with alcohol use disorder. They provided breathalyzer samples 3 times a day. And the outcomes here are also fairly large, as you might expect. Abstinence rates were 85% in the CM group versus 35% in the control, which was a monitoring only control group. These are the results of a systematic review conducted in 2019. Up to that point, only smoking and alcohol were available. These are only randomized controlled studies. So these are effect sizes for percentage negative samples and longest duration of abstinence. So relative to in-person CM, we don't see anything less effective or efficacious with technology-based CM, although some non-inferiority trials are probably warranted to directly compare. And since then, there's been a change in terms of an expansion in terms of illicit drugs. And here's, I'll provide just two examples. Here's one. This is an example where the platform was integrated into usual care community-based treatment in the Boston region. And this was again conducted by Dynamic Care Health. So 75% of the samples here were of alcohol using a breathalyzer, and 25% were conducted using the Alere 9-panel saliva test. So in this study, this is a feasibility and acceptability trial. They found that it was feasible, it was acceptable, there was high rates of engagement. There was greater retention in the CM group relative to a treatment as usual group. But rates of drug use and alcohol use were relatively low in both groups, the treatment as usual and treatment as usual plus CM. So there's kind of a floor effect there. So no difference in drug outcomes. But nevertheless, it was well integrated into the community-based setting. And here's another conducted by Anthony DeFulio. Again, inner city patients diagnosed with opioid use disorder. This is integrated into usual community-based treatment. And here the CM targets are more expansive, which is another kind of interesting feature of technology-based CM. It's easy or easier, arguably, to target multiple behaviors relative to in-person, because many of these can be automated. Many of the targets can be automated. So they targeted in-person counseling, negative urines. In this case, these were performed by the clinic and not by saliva tests by the end user, and also completion of cognitive behavioral therapy modules. And the odds ratio is 4.84 at 4 months compared to match controls. So I mentioned Dynamic Care Health a few times, and they're part of this rise of digital CM companies. That's really exciting to see, and put this into context in terms of digital health for substance use disorders. This is showing funding for startups focused on substance use disorders. In 2009, it's about $100 million. And then when this slide was created in 2021, year to date was over $400 million in startups, in funding for startups. So kind of putting the rise of digital CM into context here. One business model here for digital CM company is direct to consumer. And so this is QuitBet. We also published a feasibility and acceptability trial in 2021. Currently, there's an SBIR randomized control trial that's underway, where we're looking at efficacy and developing a sustainable business model. So this procedure here is a deposit contract procedure. So the end user provides some of his or her own money to enter a social game. And if they are abstinent, they could potentially win the game and recoup their deposit. And also, if others lose in the game, they'll recoup those deposits as well. Other companies are using a different business model in which the customers are healthcare systems, insurance companies, also patients. And this is a list of companies that I'm aware of, and I apologize if I'm missing any, but this is really an exciting development to see this list of companies that are doing digital contingency management that has great potential for increasing the scale. So the existence of these companies implies that the companies have financial incentives. There are customers willing to pay for these services, and the customers, like healthcare systems and insurance providers, are reasonably convinced they'll experience a return on investment. I think there's good evidence, there's a good argument to be made. We have good cost effectiveness data for in-person contingency management. We don't have any good data with technology-based CM in terms of cost effectiveness or any kind of health economic data, but arguably it would be more cost effective once the system is developed with digital CM. Here's just one example of the offerings of one of these technology-based CM companies. This is Vincier, and these are some self-reported the self-reported demographic groups that they're serving currently. I don't know the absolute numbers that went into these calculations, but it suggests that they are targeting more vulnerable populations. And you can see here in the lower left corner, they're also using facial recognition software to fully automate digital CM for smoking. Seeing this initially, it kind of got goosebumps, but I don't get out much. So. In terms of in the science domain, Darla Kenzor is also spearheading facial recognition software and fully automated digital CM. And this is the more expanded portfolio of drug targets that Dynamic Care Health is focusing on. Perinatal smoking, alcohol use, opioid use and stimulant use disorder, youth vaping, and cannabis use disorder. And so showing the full pipeline to commercialization for these products. So the title of my talk suggested that I'll examine the future trajectories, potential trajectories, plural, of digital CM. But as I thought about the question a bit more, I thought it was more parsimonious to suggest that there's only really one future trajectory, and that's the trajectory that we're already on. And that's impact will continue to increase, and I think we'll see more fundable and equitable models of digital CM. I mean, in 17 years since this started, we've seen several advances in technology-based CM. Drug sensing technologies have increased from smoking to alcohol to illicit drugs. We've seen the expansion from local to nationwide samples. We've seen the advances in software permitting the automation of all features of contingency management. And from just sort of one research group to many research groups and now digital CM companies. I want to address the issue of equity briefly. There's a lot that could be said here, but two of the most relevant ones are the digital divide problem. There's not a whole lot of leverage as a researcher in the digital divide problem with respect to some of these components, but there is in terms of cultural responsiveness. And I think we can do a lot more in terms of developing culturally responsive methods and research programs to make the treatments more acceptable, which will therefore potentially increase uptake. And I think Kate's talk this morning beautifully illustrated all of that. There's also the referral problem. As we know, many evidence-based treatments for substance use disorders are not used, even if they're evidence-based. They're simply not, there's not a referral to the treatment. And I think that could be the case as well with digital CM. Anthony DeFilio has an interesting article where he described an incentivized collaborative care model. I won't go into it, but I'll recommend his article. It's a very interesting proposal. But we were also interested in the referral problem. And so we recently received a P. Corey Award to evaluate the comparative effectiveness of mobile health smoking cessation approaches among underserved patients in primary care. And we're adopting an Ask, Advise, Connect model, which has been used to connect smokers to quit lines. But in this case, we're going to adapt it so they'll be connected to mHealth therapies. And those mHealth therapies, I've already talked about Motivate. We're going to integrate Motivate with I Can Quit, which is an acceptance and commitment-based therapy developed by Jonathan Bricker at the University of Washington and validated in many randomized controlled trials. So we'll test I Can Quit alone, the combination, and the tobacco-free Florida. And here's just some screenshots of the integration of I Can Quit and Motivate. Both of these treatments and all treatments will be available in English and Spanish. And we are enrolling patients from regions with high socioeconomic vulnerability in the state of Florida. So the squares here represent committed and potential treatment sites. And this is part of the grant is also, or the award is part of a larger implementation science piece as well. So we've engaged diverse stakeholders, including insurance company executives, state agencies, including the chief medical officer of Florida Medicaid, healthcare systems, providers, and patients. So we also want to address facilitators and barriers to treatment at the patient, provider, and clinic levels, and also to answer some questions about how these tools can support larger health system and payer goals. So the PCORI study I described, and several of the studies I just described, illustrate what I would consider the heart of digital CM, which is integration into clinical care with low staff burden, high fidelity, engagement, acceptability, effectiveness, and greater equity. There's certainly more work to be done on barriers and facilitators to treatment and referral. We need more health economic data as well. But this is, or can be, a disruptive technology. And there's a critical mass of success stories that are emerging. And I think there's every reason to think that we're entering an era of impact of digital CM. Thank you.
Thanks, Jesse. Really interesting talk. Our next speaker is Steve Higgins. Steve is the director of the Vermont Center on Behavior and Health at the Larner College of Medicine here at the University of Vermont, and is the PI on 5 NIH grants on the general topic of behavior and health, including a UVM Center on Biomedical Research Excellence and the Tobacco Center on Regulatory Science. He is the Virginia H. Donaldson Endowed Professor of Translational Science in the Departments of Psychiatry and Psychological Science, and his research centers around behavioral economics and behavioral pharmacology to investigate tobacco, substance use, and other health-related risk behaviors in vulnerable populations. His projects focus on examining mechanisms underpinning vulnerability to tobacco and other risk behaviors, treatment interventions to reduce them and improve health outcomes, and regulatory science. Steve.
Sarah. Yeah, so let me go ahead and get started. I'm not sure, maybe my talk should have gone before Jesse's, but it doesn't matter. They're aligned pretty good. So I want to acknowledge my collaborators and my funding. So what I'm going to be showing is team science, and it couldn't be done without the support listed here, and I have no conflicts of interest to declare. So for the past 18 years, I've been really focused on trying to reduce smoking among disadvantaged women who are pregnant and continuing to smoke. And the equity issue there is very advantageous in the sense of reducing inequities, in that smoking during pregnancy is really overrepresented among women who are socioeconomically disadvantaged, and probably educational attainment is the best marker of that. So currently, there are cessation interventions available throughout the US in each state, and here in Vermont, and they're usually a referral to a quit line and some pregnancy specific services. There have been a lot of trials with various kinds of treatments for cessation during pregnancy. But the issue is they don't work very well. And this is a very highly vulnerable population, so we need to do better. And there's consensus across. No one's really quibbling about we have to do better. And on average, this is a little generous, less than 15%. I guess it's not that generous. It's somewhere under there. So usual care is typically a referral to a quit line. What I'm going to refer to in my talk here as best practices includes follow-up and further referrals for those who continue to smoke after the initial referral. And I already mentioned broad consensus. And so what I'm going to show, and that's what I said this morning today, is really just to show the overwhelming evidence we have in so many different areas that we have to move this forward in terms of implementation. So I'm going to focus on financial incentives for perinatal women and then mention some newer work we're doing with mothers of young children, also socioeconomically disadvantaged. So kicking off where I have the most data, and I'm going to talk to you about a randomized controlled trial comparing best practices, which I just described, versus best practices plus financial incentives. And it's among 169 women who were still smoking at their first antepartum prenatal care visit. And then we also recruited 80 socioeconomically matched never smokers, because we wanted to know, we're interested in birth outcomes, how much better might we be able to do if the women never smoked. Like we could be going after disadvantaged women who are still in their teen years and maybe haven't initiated smoking. I'm not sure, but I think it's worth knowing how the women who succeed in the intervention are comparing against the controls, but also against women who never smoked. And then I do something that's a little unusual in controlled trials, but I thought it was important. And that is this is the 5th trial that we did. And so I have a pooled data set to check on the reliabilities of the outcomes that we see in the current trial against the pooled trials, where we'll have larger numbers and could get more refined estimates. And then the other thing we did in this trial in collaboration with the Vermont Department of Health is we collected a Vermont-wide sample to assess external validity of the birth outcomes that we saw in the randomized clinical trial. We wanted to just see if the changes related to mom smoking and birth outcomes correspond with the kinds of changes you would see at scale in statewide assessments with women categorized according to their self-reported smoking status. And we'll see what happens. So the women in trial recruited who were still smoking a first prenatal care visit from OBGYN clinics in Burlington, Vermont, surrounding counties. Inclusion criteria is biochemically confirmed self-report smoking the past 7 days. That's pretty important, because if you enter women who don't smoke, they're going to do pretty well. So we want to make sure that these indeed are smokers. We don't really see much of that, people trying to scam it. Gestational age less than 25 weeks, plans to remain in the area for the next 12 months in English speaking, at least sufficiently to do the trial. And exclusion criteria, imminent incarceration, prior participation in incentive cessation study, residing with current trial participants, regular use of opioids, stimulants, antipsychotic medications, just because these medications can have direct effects on smoking and create difficulties in quitting. And then we had a large number of women who began screening, and 126 failed to complete screening, 282 were ineligible, and 176 were enrolled. 759 never initiated screening. So it's not easy to recruit pregnant women into these trials, but it's too important not to work at it. So we stay on it. So we ended up with the numbers you see. The only reason for exclusion once enrolled, this is important in order to have an intent to treat analysis, is abortion or fetal demise. And that's just convention in this area of research, that if you have fetal demise, they're excluded. And you see the numbers there of how many women that apply to, and there were no differences across groups. So all participants were assigned to what I've described as best practices and encouraged to choose a quit date in the next 2 weeks. And then once a quit date was selected, they signed a referral that was faxed to the Vermont Quit Line. And all that is beyond standard care, taking the time to actually make the referral to the Quit Line. And then the Quit Line offered perinatal specific brief phone counseling and a quit coach. And it was based on the stages of change, and it included motivational interviewing, cognitive behavioral strategies. And the Quit Line also offered women a total of $65 in incentives for completing the calls. So it's an approximation towards what we'll eventually want, but not quite on the target we would recommend. And then they were eligible for free nicotine replacement if their providers agreed. And then if they were still smoking when we saw them next, they were referred again. And then the women assigned to BP plus FI were encouraged when we were talking about a quit date to pick a Monday on the next 2 weeks, but everything else above that I just described started on that quit date. So essentially, it's just BP plus the financial incentives with a little playing around with the quit date, so we could see them each day for the first 5 days of the cessation effort. So we provide vouchers exchangeable for retail items, antepartum when they start the trial through 12 weeks postpartum. It's contingent on biochemical test results. Initially, first 5 assessments in week 1 of the cessation effort is for a breath CO less than 6 parts per million. That's to avoid confounding from smoking that occurred prior to the quit effort. Cotinine has a half-life that it takes about 5 or 6 days to clear. I'm looking at Jin Yoon right there, who actually did the study to confirm that by around 5 to 7 days, you can start doing cotinine testing, which is what we do. And then the voucher value varied. This one isn't that important, but it varied by cigarettes per day at the baseline antepartum assessment for the trial. If they were less than 10 cigarettes per day, they began at the values I'm showing you're seeing there. And then if they were smoking 10 or more, they got higher incentive values, because women who were smoking 10 or more at that during the pregnancy or have difficulty quitting. So we want to see if a larger magnitude would enhance outcomes. And turns out it really, as you see in that final bullet jumping ahead, it doesn't really matter. So I would recommend going forward that you would just use the same incentive value across people who have different smoking rates. So enough there. Subject characteristics, the women are kind of in their mid-20s. If you look, the majority had a high school education, and this is in a study in Vermont, so primarily non-Latino white. If you look at the insurance, we have private insurance here, and the majority have public insurance, mostly Medicaid insured. So I think that's enough there. Smoking characteristics, I already mentioned cigs per day, which is the important, both pre-pregnancy and at the start of, during the pregnancy, at the start of the intervention. Those are important markers, but we've already talked about them. So this is the outcome in the top. What you're looking at is 7-day point prevalence abstinence, and percent abstinence on the y-axis. On the x-axis is where we are in following the women. So second AP means second antepartum assessment, and that's usually about a month after they come into the trial. And then the FAP, that's the final antepartum assessment. That's the one where really that's what got me into this work. And that is when we were looking at Ken's slides, and Alan was asked, "What's that about that relapse 2 years after you were?" And I just heard so much of that when I was working with psychomotor stims. I thought, I'm going to start working with a population where even if it only is while the incentives are in place, it matters, and that's certainly the case for pregnant women who smoke. And so then we continue the incentives through 12 weeks postpartum, then we discontinue them. So you see a decrease like you saw in other slides today. First of all, you're going to get the decrease as you move away from delivery, no matter what intervention you're using, as far as we know now. It's true with incentives, but the dark bar always stays above the control as far out as we went with 48 weeks postpartum. And but it was only statistically significant through the 12-week postpartum period. Then if you look down in the pooled data set where we have a larger number of people in the control and incentive conditions, we only in the earlier trials, we never went out to 48 weeks. So we can only pool as far as 24 weeks. We still get the decline in both conditions, but you still have a statistically significant effect at 24 weeks postpartum. All right, so small for gestational age deliveries, significant effects of trial condition. So if you look at the upper two panels, left and right, this is, both of those are from the current trial, and it's sort of in the weeds whether you should be looking at small for gestational age in all the infants or just the infants that are term deliveries. And that's too far in the weeds to get into, but long and short is it doesn't really matter. You get a little bit of a better estimate of small for gestational age if you look at term infants. And then at the bottom, in the bottom two panels, you're seeing from our pooled data set, and okay, BP plus versus BP plus FI in the upper panels. Those are the two groups who are smoking. With the one group gets the incentives, that group has less small for gestational age deliveries, and that's true in the pooled trials to show it's a very reliable effect. And small for gestational age is a very, very serious issue, and infants that are in that have that status are at risk for complications through middle age. Early on, it's sudden infant death in the first year, and then it's other complications up through age 18. Middle age, it's metabolic disorder. And, again, we could talk a lot about some of the issues of why that's the case. But you talk to any obstetrician, they'll tell you it's not a minor outcome. So we're really excited about changing that. And then we did the Vermont-wide external validity assessment. So we have 5,000 singleton deliveries, and the upper panel is upper left-hand panel is everybody in that pool, and the darkest bar, the far left under or over S, are women who reported smoking into the third trimester. The middle bar is women who reported that they were smoking either before or during the pregnancy, but they quit before the third trimester. And then the open bar are the never smokers, and we have it broken down by insurance types. And everywhere you look, you see this graded relationship, just like you saw in the trial. So by adding the incentives to get the women to quit, you can reduce the risk for small for gestational age deliveries, but you're not going to get them back to never smoker status. That kind of makes sense, but it's still an important gain. We did a cost effectiveness analysis, and like Sarah said this morning, we use the same economist. These get very complicated, but the long and short, the bottom line that comes out of it is easy to communicate. So incremental cost effectiveness ratios indicated that in the current trial, there was a return of $4.20 for every $1 invested in the incentives, BP plus incentives versus BP only. And then in the pool trials, it went up to $11.90 for every $1 invested. in incentives versus the control interventions. So these are considered very favorable benefit cost ratios in economic analyses. All right, so Jesse helped me out. He already presented this trial, but I don't mind since I took one of his graduate students as a postdoctoral fellow to do the trial. And so we understood like this was an in-person trial, the day 5 trials that I just shared with you, but to expand reach, we were going to have to go remote, and we did, and it works very well. And the 12-week postpartum, you see that's when the incentives are still in place. 24 weeks postpartum, like in our pooled data set, there's still nice separation between the intervention, the incentivized group, and the control group. All right, the most recent thing that I've been working on with my colleagues is extending the intervention to mothers of young children. Again, the same problem, this time very concerned about secondhand smoke exposure. And what we wanted to see is if these are, again, we could kind of extend what we've been doing with pregnant women to this group. And we recruited Medicaid insured moms of young children less than 12 years of age, and that's only because they spend the most time with their moms, attempt to improve outcomes with incentives by the addition of pharmacotherapy, and then comparative effectiveness. And so 12 weeks of contingency management and 30 weeks of follow-up, 3 treatment conditions. So the first one, the best practices, very much what essentially it's the interventions that we were just talking about, except the NRT. So best practices plus incentives, the middle group, and then best practices plus incentives, and then what they call combination short long-acting nicotine replacement therapies, where you give them a patch to stabilize blood levels, and then you give them either lozenges or gum if they have cravings. And here's what we found. So we're looking at 6 weeks, 12 weeks, 24 weeks, and 48 weeks. You see the legend there. Best practices only is, I guess it's orange, and then with best practices with CM is the blue, and the purple is with the NRT. And we have a very strong effect of vouchers on the abstinence rates. And I should say about 40% of the women are also maintained on opiates, or they also have opioid use disorder. So they're a disadvantaged group, and we're getting really, really pretty nice cessation effects. And the intervention ends at 12 weeks, and you can see that we're still seeing effects of vouchers. The NRT is not adding anything to quit rates. So one way to interpret that is whatever women who may have benefited from the NRT, that's already being picked up by the incentives. And there's a possibility that the NRT is actually working against quitting. I don't think I believe that, but it could be. But if you look at that 48 weeks, the vouchers only, that's almost 18% versus 6%. So you get about a 6-fold difference in absence. Well, I should have mentioned the statistical analysis here is a repeated measures for dichotomous outcomes. And there's just a main effect of treatment condition, no interaction at the 0.05 level with time. And the vouchers alone are increasing the odds of absence almost 6-fold. The vouchers plus NRT at about 3-fold. And so this is bona fide evidence that we can use incentives to meet any standard criteria for cessation results and follow-up. So this is novel evidence. What I can tell you, we're not finished looking at the child's urine toxicology results, but it's looking like we get reductions, but not statistically significant reductions in the children. And so to wrap up, cigarette smoking remains a tremendous U.S. public health problem. It's one that I just find myself thinking more and more about, just the scale of the devastating mortality and life lost and health impacts. It's pretty awful. But it's really, we've been talking a lot about equity. It's really impacts people who are already disadvantaged, and it just drives the disparities further. And that includes perinatal women and mothers of young children, very vulnerable populations. More effective interventions sorely needed. Financial incentives are one that can be highly efficacious and cost effective. And this is really an evolution of contingency management today. I would say this is I heard more about cost effectiveness in this meeting or for contingency management than I've ever heard before. And it's pretty consistent in showing that the intervention is cost effective. And so I think for the perinatal women, the evidence is overwhelming. And like I said this morning, when the heck are we going to move this forward? You know, we're underserving women and their fetuses and their infants. We know how to do better, and we just have to get it together to offer the treatment. And so I'll stop there. Thank you.
Thank you, Steve. Okay, our third speaker and our last speaker for this session is Barbara Andraka-Christou. She is an assistant professor in the School of Global Health Management and Informatics with a joint secondary appointment in the Department of Internal Medicine at the University of Central Florida. She's also a licensed attorney in Florida. She received her JD and PhD from Indiana University, where she also completed a postdoctoral research fellowship. And she received her BA summa cum laude from the University of Florida, where Jesse is. Her research explores substance use disorder treatment from health services and a health policy perspective. And her work has been published in many substance use and health policy journals. She is also the author of a book. She turned her dissertation into a published book. It's called The Opioid Fix, America's Addiction Crisis and the Solution They Don't Want You to Have. And I highly recommend it. Baja, please.
Thank you so much for having me. It's been a real pleasure getting to work on this project because most of my experience to date has been focused on the use of medications for opioid use disorder. And so this is actually my first project looking specifically at contingency management. So thank you, Stacy, for bringing me onto this team. And there's several others listed on this slide who are involved in this project, some of whom are in the room right now. So thank you all for contributing to this work. I'm going to shift gears a bit from a lot of the other presentations. I'm going to talk about qualitative work and really looking at laws. So a bit different from what we've seen today. But actually, there have been so many wonderful presentations about the efficacy of contingency management that I can basically skip half of this first slide. Since it's been discussed at length already. So instead, what I'll focus on is really the policy context for contingency management. I think it's crystal clear by the end of today that we need to have this implemented more. And one of the potential main barriers in the US to implementation are federal and maybe state laws. I will say that there is some good news on the policy front, I think. So we have seen, for example, in California, that Medicaid is starting to cover contingency management. President Biden has publicly made it clear that contingency management is an effective tool. So these are very positive policy steps. With that said, though, there are a lot of concerns still that while contingency management doesn't violate federal law per se, that potentially providers implementing it or health insurers covering it could be somehow indirectly violating other laws. And specifically, those would be one of two. So the federal anti-kickback statute or the CMP or civil monetary penalty law. These are laws that I'm going to talk about a little bit further on in the presentation, but I will just briefly note that There was a recent final rule passed by the Office of the Inspector General. A lot of hope was going in from the contingency management community that maybe there would be an explicit safe harbor for contingency management in the federal anti-kickback law. Unfortunately, the OIG declined to make that safe harbor. However, there's I think, pretty interesting regulatory discussion describing other potential safe harbors in which one might maybe be able to slip contingency management into. One of those is patient engagement and support. And then another potential one would be incentives that are offered as part of CMS sponsored models. The really critical takeaway though, and this is the last thing I'll say on the federal law, is that it would be a fact-sensitive, case-based inquiry in an individual circumstance to look at whether the anti-kickback law or the civil monetary penalty laws have been violated. So I'm not sure that's very hopeful news for people who are wanting to do contingency management on a larger scale. But that is to say that, the federal law doesn't explicitly ban it. It's more of a, we're going to look at it on a case-by-case basis. That's the current approach. So that's a little bit about the federal law. Now I'm going to switch gears into talking about the state law. So to date, we actually know very little about what do states explicitly allow or prohibit when it comes to contingency management for substance use disorder. So the overarching goal of this project is to essentially identify what are the state laws saying in their statutes and regulations about contingency management with respect to substance use disorder. Now, when we started this project several months ago, we pretty quickly discovered that there's not a lot in the state laws that is explicitly about what we would think of as contingency management for substance use disorder. So then we came up with three slightly different sub-aims. So the first is just to look at incentive structures in general for health behaviors in state laws. And the purpose of this is to be able to say, as advocates to policymakers, look, we're already doing incentives for health behaviors in other contexts. And maybe it's not officially what we would term contingency management, or maybe it's not technically in substance use disorder, but this whole idea of offering incentives for positive health behaviors is not some, shocking new thing. It's something that's been done. So we're looking for laws that fit that criteria. And then more specifically, laws that are about providing incentives within substance use disorder treatment. Again, not necessarily specifically the textbook definition of contingency management. And then finally, because of this big concern at the federal level about the federal anti-kickback law, given that states have their own individual anti-kickback laws, we also are going to be looking at the state anti-kickback law language to see whether there's anything explicitly prohibiting contingency management, or maybe implicitly in terms of providing incentives for health behaviors. I'm going to kind of quickly run through this. All of this slide is basically to say that we have a very rigorous policy surveillance process. We use a legal database called Nexus Uni. We developed a very complex search string. It's not on the slide here, but it's basically composed of a combination of terms related to incentives, rewards, and then health or health care. And we looked at state statutes and regulations, as well as those for Washington, D.C., and these are current laws. Of course, we can also eventually look at this longitudinally and work backward in time. So the inclusion process is pretty lengthy because this is qualitative work and there's room for error, and it's sometimes subjective to decide whether a law actually belongs in this data set. So we had 3 independent legally trained reviewers independently use these search terms in each state and then identify what they felt met our inclusion criteria. And they then would get together and discuss any discrepancies in what they felt should be included. And then I was the final decision maker in the event of some argument, which was pretty rare, I would say. Then we loaded it into a qualitative software called Deduce. And once again, went through a similar process. So now you have a smaller sample, but again, looking carefully at those same laws, but now picking the specific part of the law that is relevant, keeping in mind, you know, some laws might be 20 pages long. So obviously that's helpful to zone in on what part is actually relevant to our work. Again, independently done, and then discussion of discrepancies. And then I was the final decision maker. Okay, so with respect to the inclusion criteria, ultimately we included a law if it was an anti-kickback law in the healthcare context. So, you know, if it was a kickback law for construction work, that wouldn't be included. And then we would also, or excuse me, we would include the law if it was about providing an incentive to a patient, client, or person with a health issue. I know that sounds really vague, but for example, it would not include a law that is providing an incentive to the clinician or that is providing an incentive to the institution. We had a bit of a discussion for a while about the criminal justice context, because there are a lot of incentives actually in criminal justice laws. If you ever want to take a look at them, incentives are talked about all the time. For example, in sentencing for good behavior. Problem-solving courts themselves are like drug courts. Those are basically incentive structures. So, you know, we were having a lot of conversations on our team about whether or not to include those. Ultimately, we decided to include them if they were explicitly about a health behavior, such as abstaining from drugs or engaging in treatment. But if it was just for a generic good behavior, then we excluded those. We also excluded laws that were explicitly about saving costs. For example, that would be a incentive to a health insurance beneficiary for choosing a lower cost healthcare provider. So we really wanted to focus these laws on ones that are incentivizing a health behavior versus incentivizing just cost saving for an insurer. Okay, so really quickly, this is a mixed deductive inductive analysis. In the red here, you can see a very simple version of our preliminary codebook. In black, over time, we're adding more and more codes. It's inductive in the sense that, you know, in each state, we'll start to see other unique contexts in which there are incentive structures allowed in the law or prohibited in the law for some health behavior. And so the codebook is adjusted iteratively. We'll also continue to be coding and revising this codebook over time to include the types of incentives, such as cash, if that's described, or tangible items, and any limits on incentives. I should say quickly here that, again, the coding of the laws using the codebook is conducted independently by the 3 individuals who I mentioned earlier, legally trained. I supervise them. I go in and do quality checks on about 10% of the coding, and then they discuss discrepancies and negotiate on a final code if there are any discrepancies. So our final sample of laws, after looking at all 50 states, including DC, applying our rather complex inclusion and exclusion criteria, is 291 statutes or regulations. The vast majority of these were captured because they were related to the anti-kickback laws in the state. One high-level result I'll point out here, and I'll talk about more later, is very few of these are explicitly about substance use disorder treatment. So only about 9% of those are explicitly about SUD treatment. So now I'm going to shift gears into telling you about some of the qualitative themes that we are seeing here. Eventually, there will be a database created of these laws that then could be used by health economists or whomever to look at policy effects on health outcomes. But this preliminary work is just looking at what are some of the qualitative themes across the laws. So the first theme is that we actually have in our state laws across the nation a lot of health-related incentive structures, and they appear in many different contexts. So wellness programs are not uncommon. Those typically are occurring in laws related to health insurance or life insurance. As I mentioned earlier, really common to see incentives for health-related behaviors in criminal justice system laws, whether that's related to sentencing or problem-solving courts or probation. In the child welfare system, we see laws related to providing incentives for positive reinforcement. Similarly, in the K through 12 system, including for addressing learning disabilities, ADHD, and so forth. We also see other wellness programs, not in the insurance sector, but in government employment and private sector employment. And then finally, we also see some, I would say, fairly limited amount of incentive structure laws related to substance use disorder facility licensure. Pretty small group, probably the ones of most interest to us. But, one comment I'll have here again is, speaking to advocates, it may sound like a very novel, shocking thing to provide incentives for substance use related healthcare behavior. But I hope that one thing the slide is making clear is we actually allow this already explicitly in state laws and other contexts. So the second theme is about health insurer wellness programs, because these are not, I would say, explicitly contingency management, but they're probably the closest to the idea of giving incentives for routine engagement in a health behavior or showing some positive health outcome. And these laws can vary tremendously from state to state with respect to how detailed and prescriptive they are. Sometimes they're just very vague, one sentence statements of insurers can provide wellness programs, and other times they are multi-page detailed descriptions of exactly what is permitted or illegal for an insurer wellness program. Sometimes they have very clear anti-discriminatory provisions. So for example, it'll say things like it must be available to all people regardless of their health status or their age. And then a handful of the laws that I've seen so far here will actually require an evidence base for the insurer to be able to implement the wellness program. So they can't just come up with something and say, well, here's our wellness program. They actually have to prove to the state this is a wellness program that, there's some evidence behind. Here is a really quick example of one of the more prescriptive types of regulations related to insurance wellness programs. So at the bottom here, you can see that there's a reward, but the reward cannot exceed 20% of the premium paid by the health insurer. So again, just giving you an example of the fact that we already do these kinds of incentive structures in other contexts. And in fact, some of those laws can be pretty detailed. So the third theme is about substance use disorder programs specifically. So we really didn't find all that many laws about incentive structures or even anti-kickback laws or prohibitions specific to substance use disorder programs. Like I said earlier, they are generally, when we're seeing these kinds of laws, they're wellness programs, typically in the health insurer context. When we do find laws about incentive structures for substance use disorder treatment programs or facilities or providers, they're often very vague. And I'll show you an example of one in a moment. They're really not, in my opinion, the ones we've seen so far, and we're not done with this analysis, but they don't seem to be even explicitly about contingency management. Would take a bit of I guess, argument to say that they are explicitly about contingency management. And certainly we haven't seen any that would outright prohibit it. We have also found a couple that are explicitly about mental health disorder treatment, but not substance use disorder treatment, but I'm kind of lumping them together on this slide because they're behavioral health conditions. So here is an example of what I would call a very vague regulation from Arkansas. So says here, the program shall not use incentives or rewards or unethical advertising practices to attract new clients. This is actually kind of standard anti-kickback law language. This shall not forbid the program from rewarding clients that maintain exemplary compliance with program rules and their individualized treatment plans. I mean, that's it. That's the extent of what it says in the law. So, one could potentially look at that and say, well, I guess this would probably say that contingency management isn't classified as at least in the state of Arkansas, an anti-kickback law. But again, just notice how very vague this is. It's compliance with program rules and individualized treatment plans. No more details than that. Here's a slightly more detailed law from California. This is actually not specifically in the context of substance use disorder treatment, but a mental health hospital. But I think it's a, fairly analogous, worth looking at. So here, it's a very actually detailed description in the law of how patients in these mental health hospitals can be provided rewards in the form of points, and then they can go ahead and redeem these points. So the highlighted portion here reads, individuals redeem their points for desirable items or activities in incentive stores established by the hospital for this purpose. Items and activities in the stores are selected and priced according to a recovery-focused wellness economy. So, again, just another example of something kind of similar maybe to contingency management, but not explicitly so. All right. And then, as you've heard me say now probably 5 times, I'll just make it very clear that we really have not seen state laws that are explicitly about what we would call the textbook definition of contingency management. When we do see laws that we have captured in our database, they tend to be fairly vague. They tend to be about general incentive structures for health behavior. And we haven't found any that would explicitly prohibit what we would call the textbook or clinical definition of contingency management, unless you were to take some of the anti-kickback laws and think about those as potentially prohibiting contingency management, again, in the sense that maybe by prohibiting incentives going to clients for some unlawful anti-kickback purpose, that could then be argued to prohibit contingency management. So here's an example I want to show you of an anti-kickback law that's like maybe borderline. So Tennessee, this is a Tennessee statute. And so healthcare facility or provider, and this is in the alcohol or drug services context, cannot pay bribes, rebates, et cetera, to induce the referral of a patient. So one thing to point out here, and this is actually kind of common in the anti-kickback laws, it's about getting a new patient, right? It's not about existing patients being rewarded for behavior. It's more of a concern of a new patient joining you because you are offering an incentive. Okay, the second one in, again, prohibiting kickbacks or bribes in return for referring a patient or patronage. So this is like really standard anti-kickback language in that it's about different providers, not kind of, like you rub my back, I'll rub your back, I'll send you a patient, you send me a patient. Again, it doesn't feel very much about contingency management to me here. This is about, providers sharing each other's patients to make money. And then number 3, solicit or receive a commission, kickback, et cetera, in a split fee arrangement. So I think this is an example of one where if you really tried to read between the lines, maybe you could somehow argue it prohibits contingency management, but again, not explicitly on its face about contingency management. And I think it's pretty clearly not written for the context of contingency management. This really, when I look at it, at least, it really seems to be more about prohibiting unethical behavior of getting patients into your clinic in the first instance due to some rewards you're giving or some kind of provider to provider relationship that's not kosher. So several limitations to the study. First of all, we're only looking at state statutes and regulations. So what are we missing? Well, we're missing guidelines or other policy documents by agencies interpreting their own regulations. So, that's important because, for example, a lot of the discussion at the federal level has been based on guidelines and not actually so much on even the statutes or the regulations. So certainly if we have time, we might go back and start to pull state guidelines, although they're a little bit harder to access than the federal ones. And then finally, we're focused here really on the state laws, but obviously, in this federalist system, they could potentially be preempted by other federal laws. So some key takeaways, it does appear that there are incentive structures for health behaviors in the states that are permitted under state laws, and they in fact occur in many different contexts, ranging from health insurance to government employment to K through 12 education. So again, not a bizarre, unusual idea to start offering incentives for health behavior. What's really unique is that we're talking, I think, about it in the substance use context. And then very few of those incentive structures that we found are even explicitly about substance use disorder treatment. Finally, the anti-kickback laws, again, you could, if you tried really hard, maybe try to read in between the lines and think this applies to contingency management, but at least my reading of the state statutes and regulations on their face don't look like they are applying to contingency management. That's not to say, however, limitation again, that maybe a guideline doesn't exist out there interpreting that regulation in such a way that it would apply to contingency management. So overall, good news, I guess. It doesn't seem to me that there is much in state laws that is prohibiting the kind of treatments that we have talked about today. But again, a couple of grains of salt to take with this study. So I'll end there. Thank you.
Great. Very nice presentations. If I can have you all come up and have a seat, we'll start the question and answer period. And please queue up here if you have questions for the presenters. Looks like Charlie has one already from those who are virtual.
Yeah, we have a question from Erica Cruvinal asking if Dr. Jesse Dallery could comment on innovations in technology-based CM to increase treatment engagement, such as medication adherence.
Sure. Yeah. Good question. So yeah, technology-based CM has been applied to medication adherence, HIV, antiretrovirals, anti-diabetics, all with very good success. So that's not a target that I focused on. It was drug abstinence, but it's certainly another area where we see huge expansion of technology-based CM, and I think even more potential. Yeah.
Thank you.
This question is also for Jesse. I understand that within the last year, there was a large meeting at the NIH on oversight of apps and health apps and all of that. And one of the topics is whether or not these fall under the oversight of the Food and Drug Administration, whether apps are going to need to be approved by the Food and Drug Administration. As somebody who did medication research for 30 years, I hope not. But on the other hand, I've also been advising states about products, these app products. I have no basis upon which to say, this is a good one, this is a bad, other than marketing material.
Mm-hmm.
And I'm reluctant to cite marketing material as data.
Right.
And I've actually made some recommendations and gotten some negative feedback. Like, we tried that, it was terrible to work with that company, it didn't work. What's a consumer? How do people make decisions about which of the products are that they should be investing in or purchasing?
Yeah, that's a great question. I don't think I have a great answer to it. Unfortunately, I did see that seminar online though. And yeah, it's a trust issue. If the FDA approves of a device, it's more likely one can trust it. But that also presents some problems, I think, to have an FDA approved device. If we need to make changes to the device, do we have to go back to the FDA and get that approved? And what we've seen is that, every 2 to 3 years, technology changes, and therefore our methods will as well. Also, the expense about getting these devices approved at the FDA level, that gives me some pause. I really don't have a great answer to your question about how consumers can get through the increasing number of apps out there for health. Right now, we still have just a few that are available in terms of digital CM, but it's a great question.
Trade organizations form oversight to provide a consumer reports kind of thing.
Yeah, to approve the apps. That is also a possibility. Jonathan Bricker and McAfee have a great piece in Addiction editorial on other methods, not FDA based or approval based, really relying more like quit lines, working at the state level and getting state funding, government funding, working with university-based groups or private groups, because those other methods are time-consuming and they're not. They have their own issues. So it's a great question. Yeah.
Can I ask a related question? Steve, go ahead.
Well, what I found myself sitting here wondering about is the viability. I'd like to hear from Jesse or anyone else in the audience of a not-for-profit company that would provide apps.
I think it's viable.
Jesse, I wanted to ask too, you've used Motivate, but I noticed it wasn't listed like when you were showing other companies. What is the status of Motivate? Like knowing who's been involved in its development and who's using it, that to me says that that's a more trustworthy application to use, but.
Right. Motivate, the software developer, Mike Kabinski, has moved on from Motivate and it did not commercialize it. We're working with a new group. They're affiliated with Jonathan Bricker, and he's not in favor of a commercialization approach. So he would like to go more of a potentially nonprofit or state level approach. So that's what we're looking at in terms of further dissemination and implementation. So yeah.
Thanks.
Sure.
Brianna.
This is another question about technology-based CM. So I was really interested to see what you're talking about with like kind of these proliferation of all these glossy apps with all these bells and whistles that kind of get added on. And I was curious, I was wondering if you could comment on the effects of all those kinds of bells and whistles. Like I saw there was like the facial recognition technology. It seemed like there was also one that had like location services.
Right.
And thinking about, the people who are trying to use this with opioid use disorder, stimulant use disorder, like I won't even do 23andMe because I don't want them to have my DNA data. I'm wondering, like, if you could comment on, the effects of like adding all of these extra features. Do you think that's going to affect the acceptability of these technologies?
Yeah, so great question. I think it could accept the acceptability in terms of the customers who want to use them. So state agencies or healthcare agencies, insurance companies, I think it could have an impact in terms of acceptability. There are no data around that, but in terms of acceptability for the patient, it could get confusing. And I think that's a thing that we pay careful attention to. We really want to have a simple, streamlined approach. Digital literacy is a barrier to many of these treatments. So we don't want it to be confusing. It can be challenging even to take a selfie for some individuals. So we really want to minimize those bells and whistles as much as possible so we can focus on the core ingredients of CM. That's really what's doing all the heavy lifting. So I do think it can have an impact on, who's buying the app, for their patient population, but for the patients themselves, I think it needs to be as streamlined as possible.
Thank you.
Sure.
I could ask all of you a bunch of questions. But Barbara, since you're here, and I don't get to talk to lawyers very often, besides Leslie, I wanted to ask you this question. First, or make this first point, which is you blew my mind. All I think about is from talking to Rick and to Wesley and to others is about the federal regulations. I had to leave the room when you mentioned state regulations. I didn't see measure because I didn't want to hear the bad news if there was any. So I've been involved in two other kinds of work. One, cannabis work, and sort of watch the state proliferation, because I'm from Washington State, watch the proliferation of new cannabis legalization laws. And then also I got looped into this random project on model ordinances of behavioral health facilities, which I thought I never would be involved in. I don't wish that on any of my other colleagues. But it got me to thinking about, is it better for us to stay, this is sort of a question, I guess, for everyone. Is it better for us to stay on the DL and not say anything at a state level or even at a federal level? Or should we be thinking about something like, and I don't know if I'm using the right term, but like a model ordinance, like, should we be doing, and maybe that's the point of your project, should we be doing model, laws, writing our own draft laws or legislation so that other states and other jurisdictions could consider it?
Yeah, I love that question. So I tend to be, and this really comes from my experience looking at medications for opioid use disorder, on the side of let's not overregulate effective treatments. I tend to not want to see state regulations, for example, telling doctors what dosage they can use with buprenorphine or that they need to have counseling, et cetera, et cetera. On the other hand, I do think there is something potentially useful about a model law here. I would have to think about it a little bit more, but that is a potential work product that our group could think about after reviewing these laws. We could think of, well, what, if a state really wants something, like maybe this would be one approach that would at least make it very clear to providers and insurers that contingency management isn't prohibited. So I think the big issue that I alluded to at the beginning with the federal law, and it could be an issue with the state law, it's not so much that there's some law out there explicitly prohibiting it. It's more this like ambiguous fear of like, well, but maybe there's something like lurking between the lines of the anti-kickback laws, right? And so, to your point, I mean, maybe having a model law that is totally unambiguous and makes it crystal clear that this is an exception, maybe in this field, this would make sense.
Yeah, because like you said, even the OIG office, I should have that right down by now. The OIG opinion is still ambiguous in a lot of ways.
Yeah.
And that case by case determination
Yes.
piece makes it super hard to figure out unless you want to pay for it and wait for it. So
Exactly. Yeah, great point. Thank you.
So I'm from a large healthcare system in the Midwest, and I will tell you, if something is ambiguous, our attorneys will not let us do it straight up. So
Great point. Thank you.
We have a few questions from folks online. We have Yukiko Washio for Dr. Higgins. Do you have any data on breastfeeding outcomes in the smoking cessation trial with postpartum women?
Great question. And we do, what I should have mentioned was there's two papers in preventive medicine on what I presented, aside from Allison's paper, the remote intervention, and the most recent work with disadvantaged women. So the work on the individual and pooled data that I showed, that's one paper in that's already online, on which I'm first author, a second paper doing the cost effectiveness, on which Don Shepard is the first author. Those two papers will be coming out in November in the hard copy of the special issue from last year's VCBH conference. So to breastfeeding, what we saw is that promoting abstinence did not increase breastfeeding rates. And what I think is going on is it seems to be that women who are still smoking have been encouraged at this point to breastfeed nevertheless. So what you get with the incentive program is a higher proportion of women who are both abstinent and breastfeeding, but you're not seeing overall increases in breastfeeding rates like we saw in early trials. And I think just the the recommended care for breast feeding has changed over time. And right now, I think pediatricians and other primary care docs are recommending that those who smoke, that the benefits of breastfeeding outweigh the detriments of potential nicotine exposure from breastfeeding. So, yeah.
And then from Donald Shepard, we have two questions for Dr. Dallery. First, contingency management has proved efficacious for increased physical activity such as steps. How can one ensure that the person taking the steps is not another person or even the participant's pet?
Yeah, that's a good question. For physical activity, that can be challenging because you could put an accelerometer on your dog and get some steps in that way. So with those kinds of behaviors, it's not foolproof. To me, honestly, I don't get too bothered by that. If we have, say, out of 100 cases, if we have 60 that are successful and 2 who cheated in some way, I mean, I'll take those numbers. So in our case, though, we always verify that the person leaving a breath sample or saliva sample is actually that person. So that's not an issue in terms of drug abstinence. So, yeah.
And the second question from Donald Shepard is, for the business case, having collaborated with Dr. Higgins in the economics of the study in pregnant women, the 11.9 benefit cost ratio was based primarily on the economic value of better health, not on saving in health costs. Given that, how does one build the business case for contingency management?
I'm a behavioral researcher. So,
That's his supposed to answer.
yeah, I don't have a great answer to that question. I don't know if anybody else
Just
does.
so everybody is clear, Don Shepard is the economist who did
Sit
the
by
analyses in Sarah's paper mine. So Don, that's your question.
Anybody else in the room want to speak to that? All right, Kelly, you're up.
Hey, Jesse, I got 2 questions. So one is really interesting to see kind of a bigger picture of the data, these applications specifically for like smoking abstinence. One area that I'm becoming increasingly interested in is like telemedicine and interventions for people with other substance use disorders, say psychostimulants and opioids. And it does strike me that the testing technology for some of these substances lags behind maybe where the apps are. So in other words, like it's fairly straightforward to get a breath sample to confirm smoking abstinence, but it gets a little bit trickier to do testing abstinence for, say, opioids or psychostimulants. So I wanted to ask about your thoughts on not only like what are some of these like obstacles or barriers that we need to overcome in that area to make it more easily to disseminate. And I guess the second part of that question is, like, we know that CM works, like that's pretty well established. And so we're kind of trying to move towards facilitating access and dissemination. So like, do you feel like we're at a point with these apps, like we have overburdened healthcare providers to where we can just make a referral and then these companies are able to run with it? Or like, it seems like there probably needs to be some like integration work so that it actually makes the system more efficient rather than just one other thing that we're asking providers to do. So a lot of words, but 2 kind of big questions. A, like about testing for these other substances, and then 2, like how do we integrate to make this more easy for people to access?
Yeah, so I think that I'll start with the second question first. I think that is the great hope of digital CM, that it can be integrated into systems of care in fairly seamless ways, because it takes a lot of training, a decent amount of training anyway, to get someone up to speed with CM and to implement it for long periods of time, whereas an app can do it. The science is in the app. So I think that's the great hope, that it can be integrated, and we see examples where it has been. So there more work needs to be done in that area, to implementation science work to examine exactly what are the facilitators and barriers? In terms of the devices to assess drug status, yeah, that's been a continuous issue over time. The monitors we started with were actually very expensive monitors. And the question then was, well, it's not scalable. These are $450 monitors. Well, that has shifted over time. And there's more I could say about carbon monoxide monitors. It's a long story there. But with respect to other drugs as well, that's shifted in major ways over the last 20 years since we've been doing this work. I can't say that any method is perfect, right? There's no perfection, but I don't think that should be the enemy of the good here. It can still work. CM can still work given some of these limitations, and I don't think that should. I would say it shouldn't stand in the way, but there's evolution can still needs to continue.
Good.
Yeah. One thing I think we have to be careful about in terms of, so today we really wanted, the presentations were selected. We wanted to give a broad view of the diverse kinds of applications of CM and the evidence for efficacy, and we've got cost effectiveness. But in the past, what's happened is policymakers in terms of grants start saying, oh, CM works, we don't need any more grants on CM, that's a done deal. But I don't really see it that way. What happened is we weren't doing a lot of the parametric work that we should have done. There are a lot of, I would guess, the people who are challenged with implementing in California wouldn't agree that we have all the answers. How long, what magnitude, what happened, should we assume like we've kind of reached a point, I think, with buprenorphine and methadone for opioid use disorder, that it should be a maintenance treatment. Well, is that true for CM? Ken's data was suggesting, yeah, but the data for pregnant women, not as clear, a slam dunk on that. I think there's benefit. I would say there's benefit for maintenance treatment for these disadvantaged moms, but I'm not sure that we have enough data to just say that that's the only way to go. If you did the equivalent of a taper, that you're going to get so much relapse, you might as well not have done the treatment, especially when you're protecting the child from second exposure. The even more compelling, the fetus from exposure. So I think there's a lot to be learned, and I wish NIDA or other interested, NICHD, other funding agencies would be interested. Maybe they are in funding studies that would answer these kinds of questions I just mentioned, because I think they're really going to be critically important for the implementation and we're going to hear a lot more about it tomorrow.
Other questions in the room or from online? Okay, well, let's, thanks again to all the speakers. Have another round of applause for them. And then I believe there's a poster session starting at 4:30, so it's about 20 of 4 now. So you've got a little bit of time to take a